Thank you for that kind introduction and also the opportunity to come back and hopefully give you some updates and some insights from the rheumatology point of view with lupus. Can everybody hear me okay? Yeah. Okay, great. I have my phone here, not because I'm texting, but only to keep track of time and make sure when some of my boys are going to some crazy birthday party this morning, so I always worry about injuries, so that'll be the only reason I take a phone call in the middle of a talk. So living well with lupus, I think the topic says everything you need to know, and the reality is probably that's not going to be everything you need to know, but some of the highlights of things from a rheumatology perspective is what I'm hoping to enlighten you with. If you have questions along the way, feel free to raise your hand. I don't mind if there's, interactivity is always a good thing. And similarly, I don't want people falling asleep because that's never good. So I do have some disclosures that I'm not certain if are required for this type of talk, but usually we are required to just let you know that we do participate in various things. For a lot of rheumatologists like myself, we do have interactions with pharmaceutical companies. So over the past 5 years, here's a listing of some of those. A lot of it's really not much to do with lupus, but more recently, for example, AstraZeneca, Eli Lilly, and Pfizer have had some upcoming lupus-related medications for which I have been involved with them. So in my mind, I was trying to Chris had sent me some, reviews of what people were interested in learning about at a session like this. And so it's a pretty good list of things, so I was hoping to touch on a lot of them. Familiarize you with aspects of lupus care from our perspective, talk about current and upcoming treatment approaches, which I'm quite excited about actually, and then other factors that maybe we don't give as much time to. So the impact of lupus on cognition, mental health, the impact of nutrition on lupus, and also ways, I put this one in, I think, or maybe that also came from Chris as well, that optimizing that relationship between the physician and the patient. Each of these you probably could give its own independent talk on, so I do apologize if there's certain areas you wish I did more on, but who knows, that could be another topic some other time. So I thought I would start by talking about it from the rheumatologist perspective. For example, a morning in the life of a rheumatologist. Obviously, there's the morning in the life of you coming into the clinic, finding parking, paying for parking. When clinics change, goodness knows where you're going. And then that's probably, until you get used to where you're going, that could be stressful. And then from our perspective, we come into our clinic, and unfortunately, that's not very well read, but it's just meant to show you, what a schedule might look like, where if it's in a lupus clinic like me on Fridays, for example, it's all going to be lupus patients. But a lot of times you're seeing rheumatologists or me on another day of the week where we are seeing somebody with lupus, and then it might be somebody with wear and tear or osteoarthritis, then it might be 3 people with rheumatoid. So we're always changing hats between all the interactions we have. And why do I even display that? I think it's more to give you a sense that there's always a bit of a role switch, with what you need from us, and then maybe the person we saw before you has an entirely different problem with an entirely different set of parameters that we kind of deal with. So whenever we're seeing patients, and this is in general, but actually more specific to lupus, if it's somebody new, perhaps we're asked by a family doctor to make a diagnosis, or there may be a transfer of care, it's hard to know. Sometimes the question is, does that person actually have lupus? And we know when we're seeing somebody who's new, we really need a lot of time to delve into that history. I recognize this might seem quite obvious, but there's a lot we have to do in either that 30 minutes, or for me it's usually 60, but it depends on where you go, and there's not enough rheumatologists, so a lot of times we do try to condense a lot into probably too short a time. So, we're sitting there thinking, okay, what do we have to do? Is this lupus? Is it not? If it is, how bad is it? We want to look at you, examine you, think about what the right blood tests would be at that moment, and also if we need further blood tests to monitor disease. Other things in our mind are, do we need to start something today because someone is in a clear-cut flare, versus are we going to wait till all the blood work and other data come back and then bring someone back? And then, of course, the question is, if I want to bring them back quickly, where am I going to find a spot for them? Because as you probably know, we're all oversubscribed these days, and there's probably not enough hours in the day. So those are things that we don't say out loud, but they're kind of circulating in our head. if we're seeing somebody that we've seen before, we kind of update ourselves with what we perhaps wrote in our notes or in our letters to your family doctor. And we basically have to pick up, where did we leave from, what happened, how are they doing, what are the test results, did what we wanted to do, whatever treatment we might have implemented actually work, or was it even taken? And there's always that question, are we still on top of things? Do we know we have the right diagnosis, or are there other factors coming into play? Do we need to refer somebody? So as you probably know, when you're seen in a follow-up, we probably spend half the time that we did as a new person. And sometimes I would argue probably, ideally we should see you for the same amount of time as we did that first time. But a lot of it is just the nature of how the infrastructure of medicine works. So I thought I would actually I've never sort of done that in a talk before, but just to have in your mind all of those flurry of processes that are going on in our mind, which are clearly, obviously, your concern is, how do I get better? Do we have the right diagnosis? Where do I need to go? And I'm hoping by identifying that, you kind of helps you align with what's going on in our head. So here's some examples of things that also are going on, the little exclamation point or comic strip bubble in your head, right? Sometimes it's clear that I think you and you as the patient and the physician are not on the same page. Or we're looking at the person and saying, wow, this person is in trouble, we need to do stuff pretty quickly. And then, of course, there's always the darn clock in the background, and you're thinking, oh my God, I need more time. Other factors, particularly in lupus, steroids, too much, too little. Sometimes we see people who are clearly, we need to send them to emerge. So there's a lot of variables, and yet at the same time, I think by identifying that, then we can tell you what we really want to know. So when you're a lupus patient and you are coming into our clinic, we're looking for certain things from the disease activity point of view. Obviously, that's critical. So what is your disease state in that moment or in the weeks prior to you coming to clinic? And we also want to know, have you had any flares? And I think more and more now, some places more than others talk about disease damage. So disease damage in lupus is a really important concept. I'll go into it a little bit more. But when we're in the clinic, if someone's had lupus for a long time and they've had some organs, for example, a kidney, that's been affected, and their kidneys don't work perfectly well anymore, that would be an example of damage. So someone might have either renal failure or their kidneys are partially functioning. That might be as a result of a lot of past disease activity in lupus, obviously, which led to some more permanent change. So damage is the permanent effects of lupus. And so in our minds, the earlier we treat with the disease activity, which I guess seems obvious, but sometimes I'm not sure how obvious that is to other areas of medicine, then perhaps we can prevent these long-term damage sequelae from coming forward. And we also look at what was done in the past, because if someone's not flaring but they have other damage, then we don't need to change the therapy. So in clinic, these are the kind of things that we're looking for. As you probably know, if you ever share your stories with your compatriots, with people with lupus, not everybody's lupus is exactly the same. So I'm not certain if you've ever heard anybody say to you, particularly rheumatologists, that some people think lupus is a disease. We know the 1,000 faces, but it literally may be a whole bunch of diseases that have enough commonalities, like blood tests, that we call them all lupus. But lupus has a lot of phenotypes. So phenotypes is what you see in front of you, meaning, some people primarily just get skin disease and they never even need a rheumatologist, they see a dermatologist. Some have clearly full-on renal disease, kidney disease that's very bad, and maybe they don't have other manifestations. And yet we call them both lupus, but they're clearly quite different. So that's what I mean by phenotypes. Some people go through everything, unfortunately, and over time accumulate different manifestations. So every time we're in clinic, we need to go through those systems to really make sure we're not missing something. If something new is happening, we try to be systematic, I hope, with your experiences, hopefully that's the case, and make sure that nothing new has come out. The blood tests, evaluate for disease activity and flares. So even though we hate poking people, we also like to do it primarily just to make sure we're sort of keeping a surveillance on you. So various rheumatologists may ask you to do blood work Depends. If you're flaring and we're monitoring you responding to therapy, obviously it might be every month. If someone's quite quiet, it might be every 3 to 6 months. That doesn't mean blood tests are always done, but that's usually the idea is when we give you a standing order. That's the logic behind it. The other one is obviously to monitor for drug-related toxicity too. So damage is the concept that I've already mentioned, and these are irreversible things. Damage is really important because when they've done studies, and for example, University of Toronto has they're the king and queen of lupus, Murray Urowitz and Daphne Gladman, if you do reading on it. And they really started in the 1970s a lupus cohort, which is really, I think, one of the most respected internationally. And what they found, as well as other groups like Michelle Petrie and so forth have identified, is that over time, when you accumulate damage, that is a great association, unfortunately, with mortality. And also, when you have some damage, it's almost like a marker that that person is at risk for further damage. So looking at what the damage is obviously a really critical piece when we're seeing somebody with lupus in our clinics. And so evaluating it once in a while is really important. There are scales to look at damage that a lot of general rheumatology clinics don't do. We're going to start doing them at the University of Alberta, and I'll tell you more about that shortly. So damage is slow to accumulate, but it's something that is an important feature for us as well. So I was thinking when I was just starting this talk, I'm getting to better nitty-gritty stuff, but I was thinking to myself, I'm not certain if everybody in rheumatology, like your rheumatologist, does all these things. Some of it started out as research-based things where disease activity scores were done, damage scores have been done, but in reality, is it done all the time in a formal way? Like, we get you to fill in a questionnaire? Probably most of the time not, unless you go to a special lupus clinic that does research like that. But to reassure you, when we're talking to you in clinic, we are thinking of those things to kind of evaluate, is the disease activity good or bad, and is there damage there? So if you have a community rheumatologist or an academic rheumatologist, I think the emphasis is all of us see lupus. Yes, I have an interest in lupus, and I do have probably a large number of lupus patients, more than some, say, in this area. But to reassure you that all of our trainees and all the rheumatologists around have a decent experience with lupus and should be able to manage it. And sometimes, if they have questions, they will turn to like local lupus rheumatologists, I guess, sometimes me, or in Calgary, Ann Clark or Suzanne Barr. And sometimes when we don't know, we email our lupus community rheumatologist, like lupus academic rheumatologists across the country, and saying, hey, I have this patient, I don't know what to do here, what do you think? And the beauty of this community of rheumatologists is they're very willing to share and help and provide advice, which is good. So I've told you that we should be in clinic looking at disease activity, looking at damage, looking at flares. But another important part of all of this is other kinds of what we call, the fancy term now in rheumatology is patient-reported outcomes. And it's not just in rheumatology, it's really in a lot of areas of medicine. Because these are impacted by disease, and they are probably arguably what matter to you the most in some cases. So for example, this could be fatigue, it could be your function, whether it's physical, mental function. It could be also concomitant things that are impacted by disease, so depression, and then different, I mentioned already damage, but there's patient-reported type damage scales as well. And these are just a couple of the examples. So the short term is PROs, or patient-reported outcomes. And I'm planting the seed now because I'm going to tell you about some upcoming studies that are going to try to look at this. So patient-reported outcomes, I think, have evolved more because, if I said to ask somebody in my clinic, I said, are you worried about your disease activity? They'll say often, no, I'm just worried because I'm so darn tired. Or, I'm just so stiff, I can't get to work on time. My joints are really sore. And it translates more into it from your perspective. So I think there is an acknowledgement, but it's tricky, of how we can capture that and also integrate that into how we make decisions on your therapies and your treatments. So PROs is really an important feature that is coming in lupus and is being put into like different lupus centers to try to capture. But they're tricky. So I guess the question is, are patient-reported outcomes helpful and impacting your long-term outcomes with your lupus? Meaning, do they reduce the chance that you're going to get damage and have good long-term prognosis? That is still, I think, unclear. But there are some links to the hard, nasty outcomes that we worry about, like mortality, damage. They're very linked to disease activity and damage, but there is a relationship still with these patient-reported outcomes as well. Any questions or comments? Yeah.
You were talking about the rheumatologists and senior rheumatologists. So one of my questions have always been, who is my main doctor? So I have a GP.
Yeah.
But I only see my rheumatologist once a year.
Right.
So, but there's times I feel like my GP is not getting it, and I want to go see him. So who's really my main doctor? Like, is it a GP or?
That's an excellent question. And then if you put a room full of the GPs and the rheumatologists in there, and even amongst the rheumatologists, you probably would have some variation on the answer. The reality, and actually, we looked at that specific question, like who should be the main caregiver of a person with lupus. I am this is one of the things I was going to mention, but I'll start with it now, is I'm the Canadian principal investigator for Canadian guidelines for diagnosing and monitoring lupus in Canada. So I'll talk about it a bit more, but one of the questions that came up, because we surveyed rheumatologists about this and said, what are the issues for our patients with lupus that we can make recommendations to guide Canadian rheumatologists about? And so one of them was, who is the main caregiver of lupus? And in this process, we looked at evidence of what lupus patients do better, those who have a primary rheumatologist as probably their main captain of the ship, or versus keeping most of the driving of their care with their primary care doctor. And the evidence does suggest that it's better for them to have a lot of that driven by the rheumatologist. So if you were to look at it from that perspective, our recommendation actually says every patient with lupus should have a rheumatologist as their caregiver, like their main caregiver driving control of the lupus. Now that being said, I think if someone's, if in, for example, your situation, the issues you have, you're pretty concerned that they're probably more associated with lupus-related driven factors, then it would make sense to me, and I try to tell my patients to contact me in those situations. Yeah, so there are those issues. So there is access issues for sure. There's also, some rheumatologists have different degrees of accessibility. We're hoping that with these guidelines that might change things a bit, but guidelines only go so far. The other problem is sometimes the question is also attribution, meaning is the concern that you have really lupus or is it something else? And I think because of just also access, we all say if you're not sure, start with the GP, and then they should be able to call us if they're worried that it's something more if you can't get through. I recognize that's like the rainbows, unicorns, ideal world scenario, and in reality that doesn't always happen. So I think because of all those gray zones there, it's not always what you would like. Ideal world, I think if you think it's probably lupus, you should be, I get why the family doctors aren't sure. The confidence level, I think, of family doctors in managing lupus varies a lot, and I think a lot of times it's not very high. And I think a lot of times once you have a label of lupus, then going in to see any doctor, as soon as they see lupus, they assume everything is your lupus. Sometimes that's true, but a lot of times it may be other things. And I think having a general open-minded approach is something that we need to encourage and educate them on as well. So I do think we need to educate our family docs too better about familiarity with lupus, some of the things, what is, what isn't, and then also knowing that they should be able to navigate to get you to us faster. This is a really long answer, which usually tells you that there's not a simple answer to it.
Well, no, I just think I'll go to her and have her try to make the appointment.
Yeah.
And I'll probably get it faster.
Yeah. Now, and there are some rheumatologists that see more than others with lupus, and, I can't speak for the whole lot, but ideally, that's what our recommendation thinks is that, probably you should be seeing the rheumatologist. Yeah.
I have a question that I had a doctor look after me for 25 years. And he used to run the emergency of the U of A, Dr. John Walker, and then he started his own practice. He was very well versed. He looked after me for 20 years with all my lupus conditions, along with Dr. Fitzgerald, who went to Calgary. who actually diagnosed me in 2002. And so I came to see you about 2 years ago because I realized I have systemic and neuropsychiatric and other kinds, but I do not have, as a rule, I do not have rheumatic. I do not have pain. My sister has. I went to one rheumatologist. I saw the crutches and canes. He looked at me and he sent me for a chest x-ray. You know, like no connection with pain or rheumatology or, but then I came to see you and you told me, I don't think you have lupus. And away I went. And it kind of left me high and dry. Because I've since, unfortunately, not been able to stay with you. I just wandered through the woods.
Okay.
But I still go in the hospital at least 3 times a year and have had repeated flares in repeated areas, and my kidneys are at 38.
Right.
After one flare and on and on.
Yeah. Well, I mean, you bring up stuff, but we could also talk about that after probably. But if, normally if someone has a diagnosis, we ideally, at least if they're stable, see them at least every 1 or 2 years. Depends. And other things you bring up are also long-term damage of lupus that may have flared in the past that's now, in and of itself, it's not active, but then you're living with a lot of those sequelae as well. So, I mean, that's a fair point, 100%. And I think the problem with lupus, again, is that everybody's case is different. The course is, you get through periods of remission and quiescence, and then differentiating what's activity versus damage are important things. But most definitely, I know probably not in the forum of this is the best place to do that, but if you wanted to talk about it after, and if you're interested in coming back or going somewhere else, I'm happy to talk about that with you.
I know that Stephanie has a lot of information to share with us, and I think perhaps if we can save our questions until at the end of your formal presentation,
Sure.
then we'll be able to concentrate on
Sure.
those individual questions.
Yeah.
And we want to make sure, of course, that we get all of the information.
Yeah, absolutely.
Thank
Okay.
You, Stephanie. Thank you, everybody.
Okay. So one factor with patient-reported outcomes that we were talking about with fatigue is pretty tricky. I know fatigue is probably our biggest feature that a lot of different rheumatic diseases like lupus have. And, when someone's disease is flaring, it does make you tired, of course. Damage, so when someone's kidneys start failing and they don't have active lupus anymore, but their kidneys are not at 100%, that's just one example. Those things undoubtedly contribute to fatigue. That's just one example of many. Our medications can impact your energy level, no doubt. So prednisone can make you super hyper and not fatigued, or then make you bottom out and go the opposite direction and make you quite tired. Your sleep cycles with the disease activity and also medications can be affected too. And abnormal sleep begets more abnormal sleep, which leads to a lot of chronic pain and also can contribute to fatigue as well. About 20 to 30% of our lupus patients have fibromyalgia. And that's probably because of all these other factors like poor sleep. And so everything is very interrelated and complex. And then in all of this, you're still trying to live your life, and life is hard and has stresses beyond just what our disease gives to you. So my point about fatigue, sometimes I have somebody who appears to be, we don't think we need to change their therapy, but they're still very, very tired. We go through all the various attempts of exercise, good diet, good sleep hygiene, and so forth, and it doesn't always take the fatigue away. And I think that's our hardest factor to cure for anybody. So I think the jury is out there, but I just wanted to emphasize that we do hear you when you talk about fatigue, but it's not always necessarily directly lupus activity. Sometimes it is. So that was just an important point, because I think if you surveyed all rheumatology patients, that's the number one complaint we would get before even your, say, arthritis and so forth. So some ideas that are coming out with some actually mobile applications. This is a study that we're going to hopefully do at the university in the next couple of months with a group of American rheumatologists, where we may actually ask a group of our patients to document their fatigue, for example, on a scale, on an application on your phone or your iPad or something like that. And what we're wondering is, if we had someone collect this over time and then we look at it objectively between baseline and say they come back 3 months, 6 months later. We look at our trends and then see were they flaring during any of those periods of time. It may give us valuable information. We don't know yet. But this is an attempt to kind of integrate these patient-reported outcomes that I've mentioned as well. So with regards to recommendations, I mentioned the lupus caregiver question. In the past 3-4 years, I've been involved in a project for Canadian rheumatologists called, which I mentioned, Canadian recommendations. And we want to do pharmacotherapy recommendations, meaning treatment recommendations. But in order to do that, we started out with, first of all, what recommendations do we want our Canadian rheumatologists to make for them on how we diagnose and monitor lupus? Then we're going to get to, okay, what recommendations we want to come up with for treating the disease, so Plaquenil or Imuran or Benlysta or whatever. So we started with this, and we used a new process in recommendations called GRADE. It's a long story, and I'm not going to bore you with it, but GRADE is a process that over 90 organizations internationally use. So like American College of Rheumatology, for example, and other organizations and other specialties. And what they do is they look really hard at the evidence. So it's very time consuming. They, do all this research and say, for a question like the lupus caregiver question, they look to see where's the evidence, and how good is that evidence? Like, did the person do good research that was high quality, that showed us that patients with a rheumatologist who have lupus did better than those who didn't? And so, there were studies in that example where there were more emerge visits for those who didn't have a rheumatologist, or there were more bad outcomes in patients who didn't have a rheumatologist. That's just one example. But this process also looks at, if you're going to do a test, if we recommend something, is there a risk to the patient, or is it a good thing? And also, what's the cost of doing it? And also, how much resources in the community? Because it's great for us to tell everybody to have a rheumatologist, but there are costing issues and access issues too. So these recommendations integrate a whole bunch of different values into what we say. We received a grant from the Canadian CIHR, Canadian Institute of Health Research. Canadian Rheumatology Association has supported it. The Canio, Canadian Network of Improved Outcomes in Lupus, and Lupus Canada as well as the Arthritis Society. And so hopefully this will be public in the next 3 to 12 months. We have to get it published. And we will be looking to disseminate, and obviously would approach the Lupus Society of Alberta about it as well. Because if you have guidelines and no one uses them, then what's the point? And we also need to have a patient version, because some of the evidence suggests that if patients are aware of guidelines, even if they're for the doctor, they will take them to the doctor and they're better taken up and actually better implemented. So the next part of my talk I think is more exciting than the first part, in that I'm hoping to show you directions that I think are now, I'm not sure if exploding, but close to that, are coming out with things that are initiatives here and across the world, basically, for lupus. So treatments, that's always the big question. I think Chris is going to talk about her experience in Melbourne, I think, after. So treatment in lupus is always a balancing act. This is, and I'm sorry the black didn't show up very well on the green here, but balancing the benefit of your drugs versus their side effects is always something that we are taking into account at all times. And these are just some listings of different drugs that might be used. And then on top of that, there's your other medications for any other problems you may have medically. There's also protecting your bones from the side effects. But I want to say that the crux, I think, of most of us that we would say, unless you can't take them for side effects, is really antimalarial medications, so hydroxychloroquine. And so I think that everything is a balancing act, and with medications now, the antimalarials, why do we keep saying antimalarials are so good? I think 2 years ago, was it, Michelle Petrie came and gave us a really good lecture on why they are so good. And so I'm not going to give you all her data because I think you can find that anywhere, but bottom line is, why are we always so picky about Plaquenil or Erelin, so that's hydroxychloroquine or chloroquine? That's largely because there's lots of evidence, a lot of it started in Canada in the 80s, 90s at McGill, that keeping on Plaquenil at some dose reduces future flares. It may prevent somebody from getting something new that they never had with their lupus. It may decrease the long-term need for steroids or prednisone, which is, I think, in a really important emerging area that we're seeing more and more. We have to be more careful about our prednisone. And we do know for the majority, there are exceptions, I acknowledge that, with eye toxicity and so forth, but for the majority of patients that they can stay on some dose of Plaquenil or Erelin for longer periods of time. We can use it in our younger patients who want to get pregnant or are pregnant, and also for breastfeeding. And there's not a lot of drugs that we can safely say that for, so that's good as well. Now, I have had patients that still flare on Plaquenil or Aralen, so I'm not saying it's the end-all be-all, but it's really our anchor drug for lupus. The downside of antimalarials, overall, I would argue few. Yes, there have been periods where someone's had an allergic reaction, like a skin rash or something like that. It's really the cumulative exposure that leads to the question that scares a lot of people, which is eye disease or retinopathy. Recently, the American Academy of Ophthalmology came out with adjusted guidelines for how we dose our Plaquenil. So it used to be, I don't know if you care about this, but it used to be 6.5 milligrams per kilogram per day to your ideal body weight. But for lots of reasons, ideal body weight is hard to calculate. A long time ago, I trained at UBC, and John Esdale was my boss, and he used to ask all his patients, how much did you weigh when you got married? Thinking that's like your ideal body weight. And then everything was kind of downhill by then after that. And I'm kidding, sort of. Yeah. And so I think now what the ophthalmologist identified was, no, we're going to actually just say for how much you actually weigh, that we're going to reduce it a bit, that the maximum should be 5 milligrams per kilogram per day to the actual weight. So for some of you, if you notice over the next couple of years, if you are on Plaquenil or Aralen, also known as hydroxychloroquine and chloroquine, if you notice that you are having some adjustments, sometimes it's because these kinds of recommendations come out. I think a lot of times we start at the more full dose of those meds, and then over time, if someone's stable, we will gently try to drop it down. Smaller people may start with a smaller dose. And the other I will acknowledge too is the retinopathy, if it happens, is often irreversible. So that is the one crux that is scary, I think. And I think with education and communication, usually we work with our partners in ophthalmology, but we can't say it's nothing. It's not negligible. But in a practice of like 300 or 400 lupus patients, I've had one with a retinopathy. What does that mean? It's hard to know, but that one was enough to, make you feel, you still have to have a healthy respect for the bad parts of our drugs, I think. So steroids get a bad reputation, but the good parts of steroids they are a lifesaver for people with lupus. So when someone in an acute flare, it's the fastest acting emergency drug we have, whether it's oral, intravenous, injected in a joint, or even what they call a depot injection in your muscle. And undoubtedly, we need them for flares. They get a bad reputation because they can do a lot of kind of nasty things, like our little friend here. They can do, over long-term exposure, increased risk of infection, thinning of the skin, osteoporosis, so thinning of the bone, which could lead to fractures in places that normally you would not get, like hip, ankle, the spine, and so forth. They can affect your personality, like while you're on them, and make you more irritable. Some people get mania, so super hyper, or they get depressed, or they go both directions. They make you eat more. They redistribute fat, so a lot of people get kind of the moon faces, they call them, or they get a hump of fat on the back. A lot of that fat redistribution does go away or reduce, depending how long you've been on them for once you discontinue. So there are a lot of side effects on them, which is why, and there's more evidence now that they contribute to some of the damage that we see in lupus patients. So yes, lots of disease activity uncontrolled causes damage, which then we can't reverse. But steroids may be also a big player in there too. So there's this awkward relationship where we need them, we love them, but we hate them, but we need them still. And so I think more and more now, there's trials in the UK, they're looking at rituximab and limiting how much time the person's on steroid for lupus nephritis. So they're doing a trial, it's not completely out, we just heard about it a while ago. And I think it's just reflecting on the bad parts of steroid, but utilizing them when they're good acutely in the flare. So our recommendations for steroids, ideally the lowest effective dose for the shortest period of time. In reality, that's not always like that, though, so I acknowledge it. And if you look at my own practice, I wouldn't be any different. And it's sometimes those last couple milligrams, say 5 milligrams, 2 milligrams, that it can be even the hardest to get rid of. So we like to use other immunosuppressants to help taper that prednisone off. And that's where all these other drugs, which I think you might have a love-hate relationship with, are utilized, because we feel that their safety long-term is probably actually better for the most part, than long-term steroids. And so when we know antimalarials are not often enough, I'm not going to go through all of this. This was just my attempt to show you that in lupus, different drugs work better for different manifestations. So you may recognize some of the medications listed here. Lupus arthritis or uncontrolled lupus, there's lots of drugs that can work to help get somebody off steroids and help the antimalarials kick in. And the nuances of why we would pick one over the other, I think, are not necessary to go through today, but there are lots of options that we can go through. Kidney lupus, for example, has a very more specific grouping of drugs that we would use, and we use that in conjunction with the nephrologists. Nervous system, which I'm going to talk about shortly, has several medications that can be used. If you have abnormalities in your blood counts, like low platelets, there's certain medications that are preferred. Skin lupus has a wide array of different medications that can be used. So my point here is there are a lot of treatment approaches that we think about when we're seeing you in clinic. So we have newer drugs. Mycophenolate mofetil or Cellcept, it's not that new, but it is something that I think increasingly in lupus has an important role. You've heard about Benlysta, belimumab, rituximab, Rituxan. Abatacept Orencia is more for rheumatoid arthritis, but once in a while we use it in lupus, and there are some trials in nephritis still going on. And then one I'm going to talk about in a minute, anifrolumab, which to my knowledge does not have a trade name yet. And then there's clinical trials going on. So anifrolumab, this is where immunology, you get a immunology 101 lesson in when you work in rheumatology. So have people heard about this one? TULIP study, anifrolumab, AstraZeneca medication, some shaking, some. So this is a medication that I think has a lot of promise in moderate to severe lupus, more and more than anything that's come out. In my opinion, its data might be better than Benlysta was, for example. Right now, internationally, there's a phase 3 study. So this is, I think they want to recruit 1,600 patients across the world. And that study started because the phase 2, so do you guys know a bit about how trials work? Like phase 1, they take healthy volunteers and they just make sure that they don't, not that they don't kill them, but that nothing super bad happens when they, 10 to 15, probably university students wanting to make some money, make sure the drug's okay. Actually, and before that, they do animal studies, right? So it's slowly, clinical trials start with small numbers. Phase 2, they take maybe, depends on the study, like a couple hundred or less, and they try to figure out what doses of the drug work, and they look to see, does the drug work? So, and they did the phase 2 study for anifrolumab for AstraZeneca, they found that it actually, at a year, 50% of lupus patients had a significant improvement in lots of different of the disease manifestations, and they had a notable drop in their prednisone use. So now they're doing this phase 3 study. We're not recruiting here. To my knowledge, in Canada, they're not. Maybe McMaster, but they didn't really do any sites in Canada, but in the United States they do. And so this drug blocks something different. So if you remember, if you know about rituximab or Benlysta, they worked on B cell kind of stuff. So B cells make antibodies, and antibodies are a big player in lupus. And anifrolumab blocks, it's an antibody to type 1 interferon receptor called interferon alpha. So you don't have to really remember that, but to say that interferon type 1 is really important, and it can be involved in triggering lupus flares and activating your different immune cells. So I think this drug with the data, hopefully cross your fingers with the phase 3 information, will be really exciting. Now, what's the downside? They're strong immunosuppressants. The side effects actually weren't too bad. I think shingles came out as one thing. That's unfortunately for pretty much all our drugs, though, that our risk is higher for people with lupus on immunosuppression. The other thing was, I can't remember what I was going to say. Anyway, it'll be interesting to see what happens with that medication over the next 1 to 3 years. So I'm excited about it. I remember, it's intravenous. It's an IV every month. An IV every month isn't exactly an ideal scenario, but they are looking now, they're starting studies on an injectable version of it as well. So this is exciting in my opinion. Another exciting comment I want to make is all our drugs are very expensive, unfortunately. So the newer drugs, like even a year of Cellcept, might be about $700 to $1,000 or something like that, even though it's gone generic. So securing medications for lupus is always a challenge, but I think we're up to the challenge. if you have good third-party insurance, sometimes you get lucky. More and more now in our economy, a lot of people have lost insurance, so that's not as reliable, and not everybody has that anyway. So you've probably heard of STEDT, short-term exceptional drug therapy. You may or may not, if you have medication on it, then you would hear about it. So I was asked to mention this, and we secure a lot of drugs using this program. So this is an Alberta program through Alberta Health Services. It was started for when drugs were used off-label in Alberta, and a lot of them are cancer drugs, which are $50,000, $60,000, like super high expensive drugs, that they would, and any other off-label drugs. So for lupus, it started out with CellCept. I have like 120 patients on CellCept that get it done through STED. And so they, every year, will approve it. So as long as they don't run out of money, that's the only catch there. And STED is that Alberta Health will provide boxes of the drugs, or whatever, vials of the drugs, depending on the drug, for free if the person's insurance will not cover it. And they have a panel that adjudicates it, makes sure it's legitimate, that they're using something that's not super crazy. So, for example, belimumab, when I've used it and it's not covered, we have secured it through STED. Rituximab, we've secured that way. CellCept, we have if your insurance doesn't cover it. Other drugs are covered, like methotrexate, Imuran, Plaquenil, prednisone. But this is going to probably continue to be an issue for us if some of these newer medications come out. Because, for example, Benlysta is $36,000 a year. So, and nifrolumab, I have no idea how much it costs. We always told the company if they made it cheaper, a lot of people would use your drug. But the realities are all the new biologics are very costly, so we'll have to rely on such kind of services. The other area to get medication exposure is clinical trials. And then sometimes the drug companies will pay for things, but that's not very common. Oh, STED, by the way, this program has a 2-day turnaround. So if you apply, it's actually meant to be quick because some of these people are sick. They need their drug very quickly. And any physician in Alberta can actually access it. Some think they can't, but it's actually, you can. But a lot of times rheumatologists seem to do a lot of that. So the next couple of slides that I was going to talk about are some exciting initiatives that I know in Northern Alberta I think are going to reinvigorate maybe our lupus program here. And I know in Southern Alberta as well that like Anne Clark and her colleagues are involved in as well. So the first is a network called LUCIN. So LUCIN stands for Lupus Clinical Investigators Network. And I'm telling you about it because it's on, if you go, I printed the website on my phone here. It's related to the Alliance for Lupus Research, which is dedicated 100% to research in the United States. And I mean, it actually started, they said, the owner of Johnson & Johnson, owner of the New York Jets and a member of the Johnson & Johnson family had a daughter diagnosed with lupus. So given his prowess financially, he organized a group of researchers and said, I want to, like, what do we need to do in the next 15, 20 years to really elevate lupus research and figure out, ideally, obviously, the cure, but get the information so we can have better therapies for it. So out of that has come multiple initiatives, and one that started in the United States with a rheumatologist, one of the main ones you may or may not have heard of, his name is Peter Lipsky, is this network. So we are a LUCIN site, Calgary is, all of our Canio, so the Canadian lupus investigators, most of them are doing this. And they've fundraised over $50 million to give infrastructure to all of these different lupus sites. So then if someone has a study, we have the financing ability to have a research assistant help us do it and do all the different clinical trials that might come through, or this patient-reported outcome app is coming through them that I mentioned to you. Because their mission is to facilitate the clinical study of new drugs and existing drugs for lupus. So the patient-reported outcome app is going to be a LUCIN study that we would communicate to our patients about. And just yesterday, Paul Fortin is a lovely rheumatologist from Laval, Quebec, who for many years, he wanted to have a lupus passport for lupus patients in Canada. And this was something that he thought, when you go to see your doctor and every time they go, what drugs are you on again? When were you on prednisone? Oh, did you see your eye doctor? Stuff that you might think, oh my gosh, didn't they know that? And it's there, but it's putting the information in a quick, usable format so they know. So he has done some pilot stuff, but he just got approved for LUCIN to make it a study with them, which means it'll have infrastructure, which means we can recruit better to do this web-based or application thing called My Lupus Guide, which is really, it's a interactive kind of platform that will allow you to be able to record your stuff, and it has a lot of education modules, which we were involved in developing. So I think this is really good, because I think a lot of the upfront education part of it is needed. Canio, I mentioned to you a couple of times, is our Canadian network of improved outcomes in lupus. And so we are a site that Calgary is, and there's lots of sites across Canada. And these are rheumatologists who are interested in lupus, and we, because of Lucent and infrastructure, we can now start to collect just all these things I've told you about, disease activity scores, damage scores, and have someone help be able to do it, because otherwise the clinics are too busy. And then if there's clinical trials, they approach Canios. So for new drugs that you potentially might be eligible for, they are going to be, the Canios people also serve as a go-between, if you will. And also we do lots of different studies. There's a pediatric rheumatologist in Toronto who wants to study if any of us have, where someone has two siblings or more with lupus. So genetic studies to look at the contribution of genetics. I mean, there's a whole bunch of other stuff going on there, but just to give you an idea that at this time there's some nice, finely marriage of different groups together so that we can piggyback on each other but get more information. At the University of Alberta, we have a clinic, me and a dermatologist, Dr. Alain Broussard, work together. It used to be the Lupus Derm Clinic, but we've changed the name to CONTACT, which stands for the Connective Tissue Disease Clinic of Northern Alberta. So twice a month, we work together all day and see any lupus patients with skin disease and other manifestations of lupus. So you see a rheum and a dermatologist at the same time, and that can be, well, it saves time in general, saves parking money, and also it means we're actually collaborating together to try to optimize and personalize your treatment. There is one in Vancouver. They have a skin clinic with the rheumatologist as well. And then the lupus clinic that I've been involved in, we have a name for it, it's just no one knows it. It's called LUNA, so Lupus Clinic of Northern Alberta. And that's where we do see new patients and follow-up patients and participate in these studies. So, and the other thing I didn't mention is, as a result of all these other infrastructure improvements, we are hoping to do a phase 2 study and me be the local PI for a Pfizer study for an oral lupus pill. We're not recruiting yet, we don't know if it's going to happen. But I think it's something that if we liaise with like Lupus Society of Alberta and let them know these are things then, that you can contact us about if you're interested. I mean, usually when we have these new kinds of trials, we in our minds already know what patients probably would need something like this. So you don't have to contact us, but if you're interested in learning more, please do. And at the end, I'll put my information up there. But it's more just to let you know that, to give optimism and hope that there are things that are coming. And I think there's a reinvigoration of all of that. So I'm going to switch gears entirely because I think fog and mental cognition was another area that it's very tricky as well. It's kind of like fatigue. So when you talk about like lupus fog, which we hear often, and I think you might experience or you might read about, it's a complicated thing. The brain is obviously very complicated. And when we wonder with somebody with fog, you always wonder, do they have active lupus in the brain? In the brain or the nervous system. So your nervous system is your brain, and it's also all the nerves. So there's the central and there's the peripheral nervous system. And so when someone has active lupus, they could be at risk for CNS or central nervous system lupus. And it is actually pretty rare, to be honest. Usually if someone has it, even if they're complaining of fog, they usually have evidence in their blood that their lupus is active, or they have other manifestations of lupus going on. But when someone has CNS lupus, it's quite dramatic and disturbing. They may have seizures, they may have, we call it encephalitis, where you're delirious, you're not focused, you're not aware of what's going on around you, and you're in and out of consciousness. Or acute psychosis is another manifestation as well. You can have stroke syndromes, and then sometimes other manifestations like an unrelenting severe headache, not quite like a migraine, although there's some question of overlap, but a lupus headache, for example. And I haven't listed all the others, but those are some of the main ones. So these are things that when someone has complaints about fogginess, we say, okay, is it CNS lupus? So we may look at these features, or is it peripheral nervous system? So that means more of you have numbness going into an arm or a leg, or you have your inability to move a limb. So there's different names, they all have bad names, but like transverse myelitis, mononeuritis multiplex, and the list goes on. So those are first and foremost what we actually evaluate in a clinic. Fortunately, the majority of the time that's not the case. But there are tests to kind of help differentiate that besides the blood tests. So, I mean, I just listed some of them here. I won't go through them. But, I mean, there's some of them are invasive. I mean, a brain biopsy we rarely do, but it is something that has been done before if someone's very concerned. And I emphasize it's exceptionally rare. But a lot of times imaging the brain with MRI, for example, sometimes doing a nerve biopsy, these are things that would be done if we really had a suspicion that something like this was going on. The problem is, and this is the complicated part, that if you don't have some of those other features, but you have issues of cognition or fogginess, there's a lot of other things too that can compound with lupus to cause problems. I listed just some of the other things that could cause similar issues. So for example, just general migraines or carpal tunnel, back pain, diabetes, fibromyalgia, depression. So these don't help. They may be an aggravating factor or the reason someone feels they're foggy or that they have cognition issues. And so it's never nice and clear cut, even though I often get the sense that people are disappointed in me because I can't tell them what they want to hear, that, yeah, it's definitely the lupus, so we'll give you this prednisone and you're good. And it's not always that, but sometimes it is. So that's what we have to try to sort through. There are also lots of meds that mess up our thinking process too. Pain medications, of course, I think that's kind of obvious. Drugs for like mood disorders, antidepressants can affect cognition, sometimes good, sometimes bad. Steroids, I think, is very high on the list of things that you worry about. I put antimalarials, but I once in a while hear people say that they get headaches or they just feel yucky on them. Most of the time that's not the case, but I put it there because I've heard that before. And some people just feel crappy on some of our drugs, and therefore, obviously, that can affect your thinking. And there's a whole other list. But I'm listing these things just to sort of make you realize that, the brain is a nice complex box where it could be CNS lupus, it could be your medications, it might be mood disorders, stress, fatigue, because even being just tired in general, poor sleep, does affect your ability to think clearly, and over time, it compounds. And so you get this kind of foggy scenario. So a lot of the work in cognitive impairment and lupus now it's really now finally just emerging. So I think I can't give you groundbreaking information today, but probably the most forefront in that area is a lovely rheumatologist in Toronto, Zahi Tuma. He's a good friend of mine, and he's absolutely lovely, lovely rheumatologist. And he's working on a tool that we don't have yet in clinic, but we would, which is basically, it's intense. I think it has like 40 questions on it, which would make anybody tired. But he's looking to sort of help say, is there an impact on your cognition, and trying to measure it in a way, because it's very hard when someone says, I can't remember stuff anymore. I swear like 5 years ago I was much sharper, or my word finding, I can't find the right word, or I just can't multitask. You have young moms and stuff who are coming in with these complaints. I think they're all legit, and we want to validate it, but it's very hard to measure it. So he's trying to come up with a way, because I guess the question is, why bother measuring it? Well, to identify that there is something different in that person. And then secondly, then say, what strategies can we implement to try to make things better? I mean, for example, but I guess this is obvious and people probably do this already. He's saying if you know that, you have a hard time finding words or forgetting things, well then you're going to sort of try to cope better by saying, okay, I'm going to write down these things. Or people in my life, my workplace, or my husband, or my kids, or my whatever, know that this happens to me, and they may be able to kind of prompt me. I know these aren't like groundbreaking things, but I think acknowledging it first and saying, yeah, there is a definite link with lupus and cognitive impairment, but why that is probably all the reasons I told you there. For some, it's more lupus damage. For others, it's more medications. So it's not all created equal. But I think it's optimistic because I think, first of all, acknowledging that it exists, because I think it was blown off in the past, is really important. And in the next couple of years, tools like this, I think, are useful that we could potentially use, and then even work on other strategies to help people. We used to send people for neuropsychiatric testing. It's really, really intense. I don't know if anybody even knows what I'm talking about, where you take these very intense testings, it's hours, and even if you're tired that day, you're going to score crappy. And then if you did it another day, you'd score better, because they ask all sorts of complex questions. So we don't do that as much because we get the information, they go, yeah, there's probably a little bit of impairment, but then we don't know what to do with it. right? So why would we put you through that for not a good reason? So we're hoping some of this may be useful. Another factor that is true, it's sometimes got a funny taboo, is mood disorders. You know, people have depression, people have anxiety, people have OCD, people have bipolar disease, mental health, whether it's truly triggered by lupus in some cases or it's a parallel issue, it's an issue. And you're only as good as all the parts of you. So, you know, I think recognizing a mood disorder if it exists and getting help is really important. So sending people to psychology or psychiatry, if that's an issue, is important. You know, a lot of it might be reactive because it's hard to live with lupus and that can easily lead to depression. But I think acknowledging it and then also often medications can help is also an important feature too. And then, you know, not hiding it. I think that I mentioned already the important partners in your life who can make your life better and help you with the coping strategies. So how are we doing for time? Okay. I'm near the end story. So I have a couple more slides and then maybe we can open the floor to questions. So the question of diet and lupus comes up. And I think everybody actually probably knows the real answer about diet and lupus, which is if you go to different websites or if you talk to different rheumatologists, there's probably honestly no specific diet that is a groundbreaking change to prevent lupus flares, prevent damage. So, you know, I actually, because I thought, what if I say something and then I'm wrong? So I went on all John Hopkins, Mayo Clinic, and also what we do, talk to our dietitian just to make sure things haven't changed. And there's not a formal diet for lupus. You know, some people will look up different versions of anti-inflammatory diets. There's not really evidence of such a thing per se. Or gluten-free, that's the biggest one that's out there right now. But I'll acknowledge once in a while people do something in their diet, whether they follow a prescribed diet in a book or online that says it's anti-inflammatory, or they cut out gluten for a significant period of time. And sometimes people do feel better. And sometimes people say that I flare less or my general well-being is good. So I would never stop someone from trying things as long as they're not unhealthy and that you're still getting your nutrition that you need. Some of that, we think, especially with gluten-free, people are actually paying attention to what they eat. So you're reading labels, you're looking and you're seeing that, oh yeah, actually, I shouldn't be having this particular product. So people might actually arguably eat better just because they're actually looking at what they eat. Therefore, I just want people to go broke buying gluten-free products. But at the same time, that's where sometimes we don't stop somebody from doing that. There's no supplements that are formally recommended for lupus. The one thing I think, though, I would formally recommend would be vitamin D. You may see some variation on the recommendations. It's slowly crept up. So I would argue on average about 2,000 international units a day is on average now what we recommend. Sometimes if someone's really deficient, you might see larger numbers, but for the average person with lupus, I would do that. Some people will try omega-369s because they have some antioxidant, anti-inflammatory. They're not formally recommended. My worry of supplements is they tend to be quite costly and they say you have to take a lot. And the truth is there's no evidence that they actually change disease activity. So from a diet point of view, it's pretty much the same as we think all Canadians should have, which is a well-balanced, heart-healthy diet. You know, ideally if you're getting the sources of your food from lots of fruits, vegetables, whole grains, lots of servings there. The breakdown of 15% protein, 50% carbohydrates, 30% fats. And moderate amounts of your meats, poultry, oily fish. Those have some nice natural sources of omega-3s. Nuts, fish, and flax are good sources. But if you looked at a general dietitian's probably website, they would probably tell you pretty much the same thing as this, honestly. If we know lupus patients may have a higher rate of heart disease in the past, so eating a heart-healthy diet that follows these things also has that benefit as well. So calcium always comes up as a question. Calcium, we used to prescribe, for example, 500 milligrams of Tums 3 or 4 times a day. And more now, there's evidence that getting calcium from your diet is probably a more natural, better way to do it than over-supplementing with pills of calcium. So, there's lots of calcium calculators on the internet, but I think a lot of us know what those are. So low-fat milk, cheese, yogurts, tofu, beans, calcium-fortified plant milks, dark leafy greens like spinach. Those are felt to be better. There was some studies a couple years ago that people who were taking calcium supplements just in the general population, there was a couple studies that there was some funny higher rates of heart attacks and stuff, and no one understands these studies, but there was more than one. And so then the feeling was there's something more literally natural about dietary acquired calcium. So you know, if you take one calcium supplement a day, that's fine. You don't have to stop doing that. But I think unless you have issues with lactose intolerance and so on, then you have to adapt a bit. Dietary acquired calcium is thought to be better. I did note, I've actually never told a patient this, but there is some question because of how it's converted that too much garlic or alfalfa sprouts may precipitate a flare. Now, I mean, I love anything with garlic in it. I don't know about you. So I don't think you need to, but it was in enough places that I thought, ooh, you know, if I don't say it, someone else, you might read about it. So I think if you had noticed that you eat foods that maybe have high content in either of those, it's theoretically, biologically possible that maybe there's something that with the breakdown of those foods in your gut, that it may trigger something in the immune system. But I'm not telling you to stop having garlic and alfalfa. I'm just saying it's out there. There is some controversy about nightshade plants, so it was like tomatoes and all that kind of stuff. But I've never told somebody to not do these things. And I don't think there's enough evidence that it's out there. But I mean, you want to know about diet, I think that's an important thing to acknowledge. So there are a couple of things specific to our drugs. Prednisone makes you eat a lot, so weight gain is common. We do, for those reasons, recommend the low saturated, low trans diets. I think Canada's going to ban trans fat soon. I just saw that this week on some website somewhere. So that'll be good. Excuse me. And so the recommendation, particularly when you're on prednisone, which makes you want to eat more and it redistributes your fat, is to eat foods that fill you up but are good for you. I mean, the suggestion is fill yourself up so you get that satiety, you know, so you're not feeling you have to keep eating and get the munchies. So try to use instead of chips or something, even though they are better in my personal opinion, raw vegetables, fruits, that kind of thing. And I think I've already mentioned this. Now, you know, like everybody else, we are all probably, a lot of us struggle with weight. And if you want to lose weight, I don't usually endorse a lot of weight loss programs. I think everybody's different, and I think one program that I do think has a lot of success is programs like Weight Watchers. They didn't pay me to say that. I'm just saying that I've seen that it's a reasonable approach to eating, and you don't have to do that. But if you're looking to lose weight, that's not bad. And I think I even noticed there's some information on some like fitness bands and stuff in the back. So actually monitoring what you eat and how much fitness that you do, like these tracking applications, I think are quite useful, because sometimes when you actually see what you actually do, what you thought you did, it's not always the same, and it can be quite telling for people as well. And last but not least, sources of information about lupus. So there's lots of, I mean, I think Lupus Society of Alberta is, and I know I'm here with them, so they didn't pay me to say this. It's where I think they're actually they have a really good support system, and they have an excellent information piece to everything that they do. So, you know, you want to look at patient organizations that are like LSA. Lupus Canada is great, and I think they're getting reinvigorated recently as well. The Canadian Rheumatology Association, which I sit on one of their committees, they have some decent information. The Arthritis Society, it's not as much lupus, but they do have that on there. They have some sources as well. And then beyond that, I know there are like Facebook pages and stuff like that. I think being aware that best and worst case scenarios of lupus and having a healthy caution when you read them is really important, because sometimes you read the best and you also read the worst. We know not everybody loves all of us, you know, in our opinions on things, and that's the nature of the beast. But I think information in patient organizations like that is really important. I mentioned to you that this lupus guide study is going to be coming out, some potential other studies, and our albertarheumatology.com is actually for all of Alberta. It's all the rheumatologists that my colleague Stephen Cates came up with. And we haven't started posting specifically stuff going on like that you might be able to participate in, but that is going to happen. So keep that in mind. It's vetted by the University of Alberta. And there's just general patient information on there too. And then that's my email if you ever want to email me about questions. I'm not saying you have to come to me specifically, but if you want to know about information about studies, you know, and with the rheumatologists, they often, we get together with all the rheumatologists in our city once a month, and if people are doing studies, we tell everybody about it, so they, you know, if they want to recruit, they keep you, but they want to send you for a study, then that they can in that regard. And in the end, I guess, It's all a partnership. I mean, it's you're the center of it all, but the cogs in the wheel, communicating, educating, goal setting, listening, I think those are all really important. So I think maybe we'll stop right there and open the floor for any more questions. We had a lot at the beginning, but.
How was lupus very first diagnosed?
So it varies a little bit. I would say on average, for most people, it would be that they may go to their family doctor with some kind of funny symptoms that a lot of it's really based on what we call your clinical history tells us, right? So, if they see that you may have features of lupus, like you're talking about joints or skin rash or hair loss, or you just say, I'm not feeling very well, I'm tired, and then they do a blood panel, which there's certain things they might see on the blood work, such as anemia, maybe the platelets are funny, the inflammatory markers are high. They may send it off then, based on what they see on you, they may add lupus-specific antibodies, and if any of them are positive, or they check your kidney function, those kinds of things, then they may say, I suspect, or they may already know that you have it, and then they would refer you onwards. That would be typical, but there can be delays, or lupus is also a great mimic of many other diseases, so you may go through a journey where they think it's 5 other things before you get to what it is. Yeah.
Do most people see an ophthalmologist versus an optometrist?
So that's a very good question. Ideally, once in a while, when you're on an antimalarial drug, we would send you to an ophthalmologist. So that's like a medical doctor with residency in ophthalmology. However, there are a lot of times the access is poor. There's communities that don't have an access to an ophthalmologist, and it's a bit of a difficulty to come to the city to see an ophthalmologist. So their optometrists are good too, and they can do a good evaluation of the eye and evaluate it for if we're screening for, say, the plaquenil toxicity.
I was on novachloroquine, and I did see my not rheumatologist, my ophthalmologist last year.
Yeah.
And he took me immediately off it. I was starting to have so much plaque on my eyes.
Oh, okay.
So I have gone on to AZA-THIOPRINE.
Right.
50 milligram.
Okay.
It seems to be really helping.
Good,
And
yeah.
I have a bit of mobility problems.
Yeah.
And I find it's helped that as well.
Yeah, good. Yeah, and so that was an example where I said sometimes the antimalarial isn't enough, or there's a reason to stop it. So azathioprine is also known as Imuran, and that's a good drug for people that, or methotrexate, for example, or Cellcept. Your dose is small, so that's good, and it can kind of help control various parts of lupus, whatever they might be.
Okay, thank you.
No problem.
Hi, I just kind of wondering, I've had lupus now for 24 years, and I was diagnosed with fibromyalgia as well as Sjogren's, and that's all come as time has passed. But I've had a lot of problems with anti-inflammatories, so I've been kind of left to, like, I don't have much for options when I'm going through flare-ups, so I've just done acupuncture and alternative types of things. But I just wonder at what point, like I go through a lot of flare-ups all the time, but I don't run to the doctor every time because half the time I don't know whether it's fibromyalgia or the lupus that's acting up. And then, so you don't know whether it's even something, any medication can do anything to minimize the pain anyway. But I guess, like, for one part of the question, I guess, is like, how would you know the difference between the lupus and fibromyalgia, or a lot of times I don't have any confidence in my family doctor when it comes to these medical conditions because he's misdiagnosed me so many times. So, then I guess I'm supposed to be asking a question on this rather than on here. But I just wonder, like, at what point, do you have, should we be following the rheumatologist, because I've had a few cases where I've been dealing with a flare for almost a month or a couple of weeks. and then you decide, okay, well, maybe I should phone, but then it'll be another month or so, or 2, or whatever, before you can get in.
Yeah.
By that time, it settles down again.
Yeah.
So like, what should a person do then to go through these flare-ups when you've got limited options, and at what point should you really be assertive in seeing a doctor?
Yeah, I mean, so you bring up lots of important points, and I mean, I don't know, hopefully this will give you some guidance. I mean, obviously, if there was a concern it's a flare, the ideal would be get in within a week to the rheumatologist. And I know you're probably secretly chuckling saying, yeah, that doesn't really happen. And I understand.
I guess by flare-up, I don't mean like my kidneys or
Mm-hmm.
something serious, and more like all the joint pain.
Yeah. So I think you bring up an important point, which is differentiating several things: fibromyalgia versus a lupus flare, versus some of the damage that you've had from past lupus disease activity, which has left certain joints just not working well and increased your risk of like deconditioned muscles. Those are not always easy things to differentiate between. If you thought it was more of a true lupus flare, one thing you could do to assist if you have this is, at least some of us do give our patients, like, the standing orders that will look for inflammation in the blood, just other clues that would help differentiate that versus, so a lupus flare versus a fibromyalgia flare. Because blood work will be normal in fibromyalgia, but it will be abnormal in lupus. That's sometimes useful if you have that access to that type of a rec. That's what some of us do. I mean, the coping with fibromyalgia flares when they occur, if usually anti-inflammatories don't work so well for fibromyalgia. They can, but they don't always. If it's more secondary arthritis because you've had damage to joints, sometimes anti-inflammatories or Tylenol work. Prednisone doesn't work for fibromyalgia, so that wouldn't be an option. So I think a lot of it becomes some adjunctive things which are not perfect, and I think we all acknowledge that. I think you might have mentioned that, like acupuncture, massage, trying to keep active, which is always hard. Sometimes people will try yoga or Pilates, but not everybody likes those things, or swimming or low impact things. So trying to stay active through those flares, we do encourage if that's feasible. It's not always feasible. People have bad joints, that doesn't always work. So I think some of those are, so differentiating what's lupus and what's fibromyalgia is one. If you're still suffering through it, I think it is reasonable to contact either the rheumatologist if you can, and or the family doctor. There is not an easy accessibility overall to rheumatology. I know this, and I know like every day we leave a clinic and we come back, and my secretary said to me on Thursday, today was National Canada Flare Day, because she said 15 people called her. So that was highly unusual. My point is and it kind of sinks your heart, and you go, okay, because can I bring all 15 people in a week? No. I don't think most of us could, but hopefully, we try to manage that by calling and getting a strategy for our patients. That doesn't always work either, but I think trying to work through these adjunctive things, differentiating if it's fibromyalgia versus lupus, once in a while it's not clear. And I think in those where it's going on and some of these strategies don't work, then if you can't get into us, trying the family doctor. If you have a great relationship with the GP, that works really well, but it doesn't always, or they say, I don't know, it's your lupus bug, your rheumatologist. And I've had that come as well.
I mean, I just feel like I know how busy you guys are, and how, there's a lot more serious cases than what I'm dealing with right now. So that's why I don't feel it's fair to call you guys every time I feel like I'm going through something, because at some point when there's something really serious going on, I want to be taken seriously and not answering the phone, oh, it's her again,
No, I think it's very nice of you to say that. Yeah.
Take advantage of your time,
I mean, ideally, there are some colleagues of mine who are trying to open like wellness centers, places for people to have strategies that are adjunctive with fibromyalgia, even if they have other, because he's talked to me because of lupus and rheumatoid arthritis. So these could be avenues, but they're not around now. So I know that's not going to help you now. So we know there is a gap in there, and I think there's work to be done. That doesn't help you today, but for what it's worth, I think you're doing all the right things.
Thank you.
Yeah.
So speaking about, I understand too, the rheumatologists, they don't have a lot of time because they're not just dealing with lupus patients, they have people with arthritis and stuff. So is it just maybe possible to maybe some kind of a checklist that could be shared with these GPs on a regular basis that, you know, when you have a lupus patient, maybe these are some of the things that you should do, like yearly, every second year, with lupus can attack your lungs.
Yeah.
And if someone's got a coughing, you would think they would send you for an x-ray. You know, so I'm just wondering if there's checklists in place that they send to them on a regular basis that says, if you have lupus patients, these are some of the things that, you know, you should be doing for them, blah,
Yeah.
blah. It might alleviate us needing to come see you so often.
Right. And I think I like that idea, and I will feed that back. And it does tie actually in, for what it's worth, to this movement to try to more formalize some recommendations, which encompass things we're sort of talking about here, sort of like baseline blood work, baseline disease scores that we should be formalizing just as a surveillance. And so if we integrate the family doctors into that and disseminate recommendations to them, I mean, I know that recommendations are a tricky thing and a lot of doctors don't ever read them, but if that was something we could implement, I will take what you suggested back. So I think it's a good idea. Yeah. Any other comments or questions?
I just want to find out if, I know that you didn't mention about it, but in fact, I just want to find out from you as, when one has lupus, does it affect your libido?
Directly, not necessarily, but I would say indirectly possible, because I think all our rheumatic diseases can affect libido, because it's some medications might. So there is this, you know, sometimes we've had scenarios where someone's on a particular immunosuppressant, not just in lupus but in rheumatoid arthritis, and they had that happen and they stopped the drug and they felt better. So once in a while it's medications. There's also other medications that can do that. Fatigue and feeling terrible because you're in a flare, it's undoubtedly impacts libido as well. Directly as a lupus flare, is that a feature? No. But indirectly with fatigue and feeling unwell, and associated with that, like depression, or even if there's actually blood vessel issues, depending if it's a man or a woman, that it's a possibility, and it has been talked about. Yeah.
In your lupus diagnosis change, I was treated for skin problems.
Yeah.
Lately, I've been having so many problems with my back.
Yeah.
Would that be a change in diagnosis, or?
So I think the tricky thing that's come up over the past hour and a bit is the term we use is attribution. So meaning you have a symptom, right? And is it because of lupus or another problem? So lupus diagnosis, like if you're diagnosed at some point, you know, there's a flare and then you're treated and then it goes away. We've had that comment in this room too. You know, we've seen patients who've had a diagnosis of lupus in the past and then they've had some damage to the disease, and then now the lupus as we define it doesn't appear. And even sometimes the antibody has gone away in some people, so this ANA antibody, for example. So in that situation, it's when another doctor looks at it and they look back, they go, oh, and now there's no evidence of lupus. That doesn't mean they maybe didn't have it before. So that's one scenario. The scenario where some people start with one manifestation like skin, like you mentioned, and then over time, sometimes they get new manifestations that come out. That can happen. When you have but every time you get a new symptom, the question is, can lupus do that? So lupus doesn't affect back pain or back-related stuff would not be caused by lupus, but it's an important thing to bring to at least your family doctor or rheumatologist, because if you're having back stuff and, for example, you're on steroids and then it increases your risk of osteoporosis, you might have something else like a compression fracture in the back. So directly it may not be the lupus, therefore your diagnosis probably didn't change, but you may have either consequences of your treatment or an entirely different issue like some arthritis or something in the back. So it's a complex answer. Yeah, no problem. Any other questions? Okay, well, thank you for your time, and hopefully that didn't confuse you, and I appreciate it, and I hope you enjoy the rest of the day.